Well, good morning, everyone, and welcome to today's webinar. I'd like to take a couple of quick housekeeping items to go over with you. First, this is a watch and listen only webcast. There is a chat button where you can submit any questions that you may have. We'll try to get to as many questions as possible during the Q&A session at the end of today's presentation. Following this webcast, we will be publishing the slide deck, a recording of the webinar, as well as a handout of all questions asked with answers from our speaker. You'll receive an email with a link to all information. Also, we will be conducting a survey at the end of this session. A link will be provided for you in the chat box. Now let's get started. Welcome to the Rybar Group webinar. Is your hospital prepared for a DSH examination? Your webinar speaker today is Brooke Yall, our Manager of Medicaid Services. Brooke has extensive firsthand experience with the Medicaid program, including work coordinating with federal regulators, state legislatures, industry stakeholders, and other state agencies to resolve Medicaid-related issues. And she has been proven to be instrumental in negotiations with CMS to get new supplemental payment programs approved. Again, thank you all of you for being here. And now I'll hand it over to Brooke.
Hello, everyone. Thank you for coming. Thank you, Claudine. So today we are going to just really talk about the Medicaid program. Here's some of our talking points, and then we'll really get into the Medicaid DSH part of it. So we'll do a quick overview of Medicaid and the reimbursement, some Medicaid supplemental payments, the disproportionate share hospital, also known as DSH program, the DSH examination overview. We'll look at the exhibits that are required for the DSH examination, some eligible patient accounts, how you can prepare for the DSH examination, the reinstatement of CMS FAQs 33 and 34, and then the Consolidated Appropriations Act of 2021. So first, what is Medicaid? So Medicaid is a federal program through which states partner with the federal government to provide healthcare coverage to low-income children, families, elders, and people with disabilities. So the federal government establishes basic mandatory program requirements, and then states choose whether to participate. And then the Medicaid program is jointly financed through federal and state. And then after kind of all that, the state develops their unique Medicaid program based on federal rules. Each program must be approved by the Federal Centers for Medicare and Medicaid Services. Also, just to know, anything that a state wants to do with their Medicaid program has to be approved by CMS, because federally, we'll talk about it later, they are contributing at least 50% of the dollars that go to the Medicaid program. So an extension of the Medicaid program is the Children's Health Insurance Program, also known as CHIP. It provides health coverage to eligible children through Medicaid and separate CHIP programs. CHIP is administered by states according to federal requirements, and it is jointly funded by states and federal government. So the Medicaid enrollment as of June 2022, there was 89.4 million people enrolled in Medicaid and CHIP. You had 7.1 million enrolled in CHIP, 40.8 million children enrolled in CHIP or the Medicaid program. And that does account for 45.6% of the total Medicaid enrollment. Since the pandemic, since the public health emergency, the enrollment has increased 26.5%, and that we'll talk about it a little bit later, but there's a couple different various reasons for that. So here's a couple snapshots. The first is before the public health emergency. As you can see, the enrollment was kind of steady, almost declining in some states, and then as soon as the pandemic hit, it started increasing. And the reason for that is Medicaid you were not disenrolling anyone from Medicaid. So anyone who was enrolled in Medicaid at the time of the pandemic is most likely still enrolled. And we'll talk about why here in a minute. So eligibility. So the federal government requires states to provide coverage for the mandatory eligibility groups. That includes low-income families, qualified pregnant women and children, and individuals receiving SSI. States can choose to provide coverage for optional groups. A couple examples of the optional groups are individuals receiving home and community-based services, children in foster care, medically needy programs, 209B. For pregnant women, 200% of the poverty level is the minimum, and then it can go up to 400%. For Michigan, it was anyone affected by the Flint water crisis. And in the United States, a interesting fact, 42% of the births are financed by Medicaid, and that was a statistic from 2020. So just to get into the Affordable Cares Act of 2010, this did have a big impact on the Medicaid program. So under the act, states have the opportunity to expand coverage to nearly all low-income Americans under the age of 65. The federal poverty level extended to at least 133% for children in every state. And the option to expand eligibility to adults with income at or below 133% of the FPL. So that is currently 40 states, including DC, have expanded. And that's kind of when you hear, oh, has the state expanded? That just means that they are now allowing adults that were not previously eligible for Medicaid up to that FPL, that 133%. And then states can choose to expand anytime. Here's a map of the states who have expanded, those dark blue. They've expanded, the orange have not. Missouri was one of the most recent ones to expand, and South Dakota has expanded. It was adopted, but it has not been implemented yet. It does take some time. So the reimbursement, Medicaid reimbursement varies by states. Fee-for-service delivery system, that is a cost-based for prospective payment system. You also have the managed care delivery system. You can have a combination of both. Medicaid payments have historically been below cost, resulting in shortfalls. And that's kind of where the supplemental payments, these DSH payments, these low-income pool payments, the graduate medical education payments come into play, is that helps hospitals and providers get to at least their cost. And then in general terms with reimbursement for Medicaid, providers cannot be paid more than their costs. So that's kind of why we're doing this DSH audit. We need to ensure that providers are not being paid more than their costs per federal guidelines. And so there's, different ways how cost is calculated for DSH. We're going to go through that, but most of the times it's through the Medicare cost report, cost to charge ratios, or Medicaid cost report. So that varies by state. Just to talk a little bit about the fee-for-service delivery system, it is reimbursement to providers that comes directly from Medicaid. Each service receives a specific reimbursement in exchange for services provided. They either use a fee schedule or a base rate, and then it's a cost-based reimbursement. So most of the times a Medicaid cost report will be due to the state. Prospective payment system is another payment type. Examples of that would be a diagnostic related group or DRG, similar to Medicare. That would be for inpatient, and then enhanced ambulatory patient grouping, also known as EAPGs. That could be an example of an outpatient. Some states, they do more of a prospective payment for inpatient right now, and then it's still cost-based for outpatient. So it could really just be a combination of both. And then managed care is healthcare delivery system organized to manage cost, utilization, and quality. It provides for the delivery of Medicaid health benefits and additional services through contracted arrangements between state Medicaid agencies and MCOs. So the state's Medicaid programs will typically pay a per member per month also known as a capitation rate to MCOs. It's actuarially sound, and approximately 70% of Medicaid recipients are currently enrolled in managed care. And you have a lot of states who still have some recipients on fee-for-service, and then majority of them are on managed care. You have some states that are just now implementing managed care. So it really varies by state. But just to know with this DSH audit, why knowing what fee-for-service and managed care is because they are reported separately. So in your accounting systems, it's really important to be able to identify what Medicaid fee-for-service is and then what Medicaid managed care, the different payer types. Some of the benefits of managed care is it reduces program costs. It's a better management utilization of health services, improves health plan performance, improve healthcare quality, improves outcomes, and providers actually get to negotiate a contract with each MCO. So there's a little bit more flexibility. The rates might be a little bit different. They're going to be at least a minimum of, I think it's usually about, I want to say it's 95% in some states of that, what the rate would be for the fee-for-service. So it's always going to be around that fee-for-service rate, but providers do get to negotiate that. So I'm sure you hear this all the time, especially when you're dealing with supplemental payments, but in FMAP. So it's the Federal Medical Assistance Percentage. It is used to calculate the amount of federal share of state Medicaid program expenditures. It varies by state to state, and it's updated annually. So the FMAP formula is based on a ratio of the state per capita income to the national per capita income. And it uses 3 most recent calendar years for which satisfactory data are available from the Department of Commerce Bureau of Economic Analysis. So the lower the state's average per capita income, the more FMAP and vice versa. But all states do receive at least 50% FMAP. Just a quick statistic, the total Medicaid spending was $748 billion in fiscal year 21. And that was including admin cost, accounting adjustments, and the U.S. territories. And so, majority of that is coming from the federal government. So when we talked about enrollment, we did kind of one of the reasons why enrollment has gone up and it has stayed up is because of this enhanced FMAP. So January 31st, 2020, the Federal Department of Health and Human Services declared a public health emergency. The CARES Act provides a 6.2 percentage point increase in federal Medicaid matching funds to help states respond to the COVID-19 pandemic. So this is less money the states have to bring to the table and more federal dollars funding the Medicaid program. So the enhanced FMAP is effective January 1 of 2020 through the end of the quarter in which the public health emergency ends. So as of, I was just double checking this the other day, the public health emergency is set to end April 1st. So that would be, this enhanced FMAP ending June 30th. So of that quarter. States accepting the enhanced FMAP must provide continuous Medicaid eligibility through the end of the month in which the public health emergency ends. So this is why states are not disenrolling enrollees. We've had high Medicaid volumes, and it is because of this enhanced FMAP. So it did apply to people enrolled as of March 18, 2020, or who enroll anytime thereafter during the public health emergency. And states may request to stop receiving the enhanced FMAP at any time without losing what they've claimed previously. I haven't heard of any states doing that, but you never know. I don't think they would want to lose that 6.2% point increase. So we talked about the federal share. Now the state share funding, some examples of that would be general revenue. And then intergovernmental transfers, so that's a transfer of funds from a governmental entity other than Medicaid, counties, healthcare taxing districts, providers operated by state or local governments, and those must be a bona fide donation. Certified public expenditures is another one, also known as CPEs. So CMS requires cost reimbursement methodologies for providers using CPEs to document actual cost of providing services. So if they're using a CPE, there has to be some kind of statistical time studies, periodic cost reporting, and then the reconciliation of any interim payments. So there's just more reporting that goes on when you use a CPE as the state share. And that's because a CPE is almost like a piece of paper. You're not actually sending the money to the Medicaid program like an IGT. An IGT, you would send the money to the Medicaid program. With the CPE, that public entity is certifying that they have the money that they could send, but that Medicaid program is just going to send it right back to them. So the Medicaid program doesn't actually receive those funds. So there is more reporting required. And then another example is the provider fee, also known as a tax and assessment. So those must be uniform, broad-based to be allowable by CMS. It's a 6% max of net patient revenue, and there can be a assessment on inpatient and outpatient. And healthcare related taxes must be broad-based and uniform. So that is, they must be levied against all non-governmental providers in a particular class, not only those that accept Medicaid payments, and the tax rate must be uniform across all providers in the class. And then providers cannot be held harmless through a direct or indirect guarantee that they will be repaid for the amount of taxes that they contribute. So once you start using the taxes and an assessment, there's just more regulations, more federal regulations that the state Medicaid programs must follow. So just something to keep in mind when we're talking about DSH or supplemental payments. So supplemental payments, so these are payments made to Medicaid providers in addition to their regular Medicaid payments for services. So this is in addition to your claims payments. These payments are meant to get you up to your cost and kind of help out, fill that gap when these providers are serving Medicaid and uninsured enrollees. So the state share funding source is generally funded through non-general revenue funds. So as we talked, IGTs, CPEs, taxes, it is authorized by the legislature either through statute or the General Appropriations Act and approved by the Federal Centers for Medicare and Medicaid Services. They're typically approved by CMS through 1115 waivers or state plans. In addition, all of these supplemental payments, including the DSH program, they have extra audits. This is this extra payment. Now, the federal government, CMS, wants to make sure that you're not receiving more than your cost, because it's very easy when you're receiving all these extra payments to go over that cost, and they want to make sure you don't do that. Couple examples of supplemental payment programs. Again, the DSH program, that's what we're all here for today. We have uncompensated care pools. They are also known as the low-income pool in Florida. Upper payment limits. We have directed payment programs. Those sometimes are thought of as pass-through payments, but CMS likes you to call them directed payment programs. We have graduate medical education. That can be direct, indirect, Medicaid enhanced payments, also have a couple of emergency medical transportation programs and some school-based programs. And all, depending on the state, it'll vary each state what supplemental payment programs are in place and how much funding is actually going to providers. So why we're here today, the Disproportionate Share Hospital Program, also known as the DSH program. DSH was created under federal law to compensate hospitals that have provided a disproportionate share of Medicaid or charity care services or uninsured services. Federal law establishes an annual DSH allotment for each state that limits federal financial participation for payments made to hospitals. So that FFP is not available for state DSH payments that are more than the hospital's eligible uncompensated care costs. Again, so these providers cannot be paid more than their costs to providing Medicaid and uninsured patients. So uncompensated care costs, it's the cost of providing inpatient and outpatient hospital services to Medicaid patients, and the uninsured minus any payments received And the total allotment in fiscal year 2022, this is the federal allotment, was $13.2 billion. Couple, the biggest states, just to kind of give you an idea of what states each state gets. California right now, their allotment was 1.3 billion. Texas was 1.15 billion. New York was 1.9 billion. And then I wanted to include some of the statistics on some of the providers that we do have on today. So in Florida, the federal allotment was 241.5 million. I'm sorry. Michigan, 320 million. Missouri was 572 million. Ohio, 490 million. And then Illinois was 259 million. So this is tons, billions. We're talking about billions of dollars that's going out to these providers every year. But the federal government wants to make sure that they're not getting paid over their costs. And that's why we have this great audit that we get to do every year. So states are required to submit an independent certified audit describing DSH payments made to each DSH hospital. And the reason why they implemented this is CMS on December 19th of 2008 just released a federal regulation that was requiring states to submit that independent certified audit. So any payment in excess of uncompensated care must be returned to the state. The state really is required to either return those funds to CMS or they have the option to redistribute it to the providers. Every state does it a little differently, so it depends on your state. And then Myers and Stauffer does conduct most of the audits in the country, and that's kind of the audit we're going to go over today. And then just to note, so the fiscal year 2019 audit was due just this past December. It was due December 31st. And then the fiscal year 2020 audit, so it's, those cost report years covering that fiscal year 2020 is going to be due this coming December 31st. So something also to think about, there's some states that are a little bit ahead. Some states are a little behind. Florida right now, I believe they will be submitting their 21 audit, but then that's not going to be due till next year. But then a majority of the other states will be completing their 2020. So again, today's focus will be on the Myers and Stauffer's DSH examination. So to start with, the state or Myers and Stauffer will send out examination letters to each provider that are required to submit the examination surveys. Surveys are typically due 30 to 45 days after the letters are sent out. And Myers and Stauffer usually will grant a 2-week extension, maybe more, depending on the circumstance if needed. And that, again, that varies on the state. The Myers and Stauffer has to get the approval from the state in order to do that. But they're pretty good at, giving a little bit of an extension. So the DSH examination survey, hospitals will need to complete 2 surveys. And there's more that's involved in just those 2 surveys, but that's kind of the bulk of it. You do a lot of work to fill out these 2 surveys. And those surveys are completed using the Medicare cost report and internal hospital data. So you have obviously survey part 1 and survey part 2, which we'll go over. So survey part 1, I always look at it as the easy one. It's the basic hospital information. You have your cost report year. Make sure you're submitting the right cost report year. Your OB qualifying questions, other Medicaid payments received during that state fiscal year. You have the certification or signature page, and then there's a checklist of all the required submission documents. And then survey part 2 is kind of where you're calculating that uncompensated care cost. You're also calculating the Meyer and Liar calculation. The Meyer is the Medicaid inpatient utilization ratio. The Liar is the low income utilization ratio. These are used to make sure you actually did qualify for the DSH payments. Myers and Stauffer will also pre-populate the data for Schedule G, and that is using the most recently filed Medicare cost report of that year, that cost report year that's being audited. So it uses HCRAS data for that. And then a couple things, once you get this survey, definitely review that. And then did you have an amended cost report? Because if you had an amended cost report, sometimes that's not in the HCRIS data yet. So you'll have to just go ahead and modify that section and submit that amended cost report when you're submitting all your other documentation. And then you also just, again, want to review all the data to ensure that they are using that correct data. Data from exhibits A through C will be used to complete sections H through K. We'll kind of go over that. I know the letters are a little hard to remember, but we'll go over that a little bit. So this is schedule H and I. H is inpatient, H is in-state, I is out of state. And this is where you're going to gather all your data from the hospital, and you're going to summarize that data. And this is where you're inputting it. This is where it's going to, there's formulas in here. It's taking the cost to charge ratios from the Medicare cost report. It's multiplying by the outpatient, the ancillary cost to charge ratio charges that you're inputting. And then it's going to output that final uncompensated care cost. The ancillaries are using the cost to charge ratio. The routine cost centers are using those per diems that are calculated from section G. And so here, this is going to be different for every hospital. Again, it's coming from your own individual Medicare cost report. So you just want to make sure you want to look over this. Does that look right? Look over these cost to charge ratios on the ancillary cost centers to make sure those are correct. Are there any, cost centers that weren't already on here? You'll have to add that if needed. So you would put the days up here for the routine cost centers, and then the actual charges. So you have your inpatient and outpatient charges. And then this will auto-populate that total in-state Medicaid. Now, something to remember, the total in-state Medicaid will only calculate these. So if you're trying to look at the final amount at the bottom, look at the next page, you have to add the uninsured and in-state Medicaid together. This is the same schedule. It's just the bottom where you're going to input those payments. And again, the most important part are these boxes right here. That's what's calculating that shortfall, that Medicaid shortfall. A positive number is a good number in this case, and if a negative, that means you were paid too much. That's really it here. I mean, you're just inputting the payment amounts, and then you'll actually see total charges, and then it will calculate the cost right there for you. So in order to create that survey part, we do need to create these DSH exhibits. So the exhibits will include patient level detail. Some of the data will come from the state. A lot of the fee-for-service or the crossover, the states will provide a PCL or a, I forget what the other state calls it, but it's just a listing of all of the Medicaid fee-for-service or the crossovers. And then some of it will need to be pulled from internal hospital records. So those Medicaid MCOs will need to be pulled from internal hospital records. I always recommend just pulling all your charges, even though the state is, giving you that fee for service. Pull your fee for service and check it. Make sure they're not leaving anyone out. So you have Exhibit A; those are your uninsured. Exhibit B, those are your cash payments. So we'll talk about that after. And then your Exhibit C's is the Medicaid fee-for-service, Medicaid MCO, Medicaid other eligible, crossover, out of state. And then, something to think about, some states might not be affected by this year, but depending on your cost report year data you are submitting, Exhibit C actually might only be like your Medicaid MCO, and out of state, you might not be submitting your Medicaid other eligible or the crossovers anymore. And we'll talk about that here in a little bit. The revenue code crosswalk used for the Medicare cost report is really important. This is probably a good time to go ahead and to open that up and look at it and see how you assigned those charges to the cost centers, because you're going to use that same methodology from the Medicare cost report to assign the charges to the cost centers. So Exhibit A, those are your uninsured patients. It's a listing of all uninsured patients during the cost report year. You're going to include charges and days by revenue code. And you need to include any patient or third-party payments received. Also must follow Myers and Stauffer template and have the minimum data fields required. But I do want to note that sometimes that minimum data field required is not enough data in order to assign those charges to the appropriate cost center. So depending on, that revenue code crosswalk and depending on your hospital accounting system, you might need to add additional fields such as the GL department codes to properly categorize those charges by the cost report line. Also note these uninsured patients, these are basically claims with no third-party coverage for a specific service, or they have exhausted benefits before services are rendered. So I would look at your accounting system and see, are you able to identify if they have exhausted benefits? How are you able to identify? So before you kind of start this audit, those are kind of the questions you want to look at all your stuff, talk to your IT department and figure out how can we identify these exhausted benefits so I can add them. And just after you're done pulling all the data, are you including all eligible uninsured accounts? And then also review your state's definitions for uninsured. I would also look at your charity care accounts, make sure that those are all being included as well. And this is just the minimum data fields required per Myers and Stauffer. And that is kind of what that Exhibit A is going to look like at the end. So Exhibit B, these are your cash payments. So it is a listing of patient payments received during the cost report year, regardless of when services were provided. So it's just all patient payments, uninsured or insured, received during the cost report year. The other exhibits are based on states of service. This is the exhibit that is based on when you actually receive the payment. So you will need to determine if each payment is insured or uninsured. And then only the uninsured patient payments will be used to calculate that uncompensated care cost. So you'll take that uninsured portion of the patient payments, and that is what's going to be offsetting the uninsured exhibit. So that Exhibit A for the payments on the survey that we looked at earlier. Again, this is just the required data fields. It's very similar to the other ones, but these are payments. So they're asking just a couple more questions. Insurance status at the time of service, if the uninsured claim is being claimed as uninsured due to exhaustive benefits. So how is your hospital, this is the time to look at how is your hospital identifying those exhaustive benefits or maybe a non-covered service. And again, that's what that exhibit should look like. Myers and Stauffer also does not mind if you have extra columns. These are just the minimum columns that you have to have. I have extra columns when I'm doing these all the time, and I just hide them. I leave them where they are and hide them, and I've never had an issue with that. So Exhibit C. So these are all your other patient types besides the uninsured. Similar to Exhibit A, it's the patient level detail by revenue code, and you're required for all paratypes that require internal hospital data. So your Medicaid MCOs, your Medicaid other eligible, your crossovers, and typically Myers and Stauffer wants to see a separate exhibit for each of these payment types. And then it needs to include all payments received per patient, and those payments would need to be broken down by Medicaid fee-for-service, Medicaid MCO, Medicare fee-for-service, Medicare HMO, other third-party payments, and then patient payments. Again, Might need to add more data fields depending on your hospital accounting system. So again, you're going to want to look at that revenue code crosswalk that you use for the Medicare cost report to see what else you need in order to categorize the charges correctly. And again, you need a separate exhibit for each. You know, Medicaid usually provides that Medicaid fee for service, but it's okay to pull that data. You're already pulling all the data. Just, I would pull it, make sure that you're capturing all of the accounts. Medicaid MCO, Medicaid other eligible, and crossover. And then this is the required data fields, very similar to Exhibit A. I think the only difference here is there's your patient's Medicaid recipient number. You're uninsured, you don't have that. And then the payments are a little bit different. And an example of what that Exhibit C will look like. Okay, so preparing for the DSH examination. I know I've kind of talked a little bit about what to do, some tips that we have in between some of these slides, but there are some things you can do now. You know, Myers and Solver has not sent out a lot of the letters yet. Maybe they have, but before you even get the letter, there's a lot that you can do. You can start gathering all your financial documents that will be used to complete the survey. You can also go ahead and request all the data. Do it now. IT department, I'm sure, is busy. You can also start gathering your financial statements, you know, your listing of other Medicaid supplemental payments, your working trial balance, that Medicare cost report, which is very important because that's where those cost to charge ratios are coming from. Just take a quick look at it, make sure that it was submitted in a way where you're optimizing your cost, everything was submitted correctly. You can start creating those logical statements that are required. Those logical statements are going to be used to tell Myers and Solver, hey, this is how we pulled the data. So you can work with your IT department to honestly maybe even send that logical statement to your IT department and say, listen, this is the data we need. And they can kind of help you with that. You want to also review prior year results. If you were close to being overpaid, or maybe if you were being overpaid, are you including all eligible accounts? Did you include all those charity accounts? Were those marked correctly? You know, did you have to look at your transaction code crosswalk to be able to identify those charity accounts, or were they just marked as self-pay? And then were there any adjustments made in prior years? So if you had large adjustments, figure out why. You know, and that's going to prevent these large adjustments for this coming year. Couple other things, you know, I think this is universal. A lot of hospitals, healthcare systems, you're having issues with staffing. So do you have the staffing capabilities? Or do you have any upcoming PTO or vacation requests? Look at that now so you can start planning out how you're going to get these audits done. You know, these audits, especially when you get into those patient level detail, they take a long time, and you need not only time to kind of put all the data together, but just sit back and analyze everything. And again, I know I talked a lot about IT, but go ahead and schedule a meeting with your IT department. Make sure you're determining if prior year search queries captured all accounts, and then does your IT department have the staffing capabilities to complete the request timely? Again, send them that logic query, kind of what you're thinking of how to pull the accounts, and then maybe they can help you. Oh, well, this is how we pull the account. You know, and again, look at your charity care policies. Are you including all those charity care accounts in those uninsured, you know, and then you can request that data as soon as possible. You know, and this can be done before you receive that letter from Myers and Solver. All of this can be done because you're working right now on 2019 and 2020. I guess it would be 2020 and 21 cost report years. So you should have all that data. Also, are there any other data fields needed in order to categorize charges in the appropriate cost center? So really now is a great time to revisit the Medicare cost report and the revenue code crosswalk that was used before you submit the data request. I like to go ahead and look at that transaction crosswalk. Are there additional transaction codes that you should be looking at? How do you categorize your accounts? Are you categorizing them by payer type, by a transaction code? So now's the time to kind of look at all that, get a game plan ready, and then you can request that data from your IT department, and then you can actually start the audit. Also, another great thing to look at would be your S10 for the year. You've already submitted that charity care listing. Go ahead and revisit that. There is a difference between S10. S10 is based on write-off date. And this is based on dates of service, but still, are you, those account types that you were included on S10 charity, are you also including them on the uninsured? So a couple updates with the DISH program right now. This is kind of an old update, but I like to kind of bring it because there was a big change in the uncompensated care. 2017 or 2018, I think 2017 was probably like the last year where it really was affected. You had all this uncompensated care cost. And so a lot of hospitals were not overpaid, but that's because of this DISH rule. It was from the CMS FAQs 33 and 34. So on April 30th of 2017, CMS issued final rule, and it was withdrawing FAQs 33 and 34 from the Medicaid DISH guidance that was issued in January 2010, titled Additional Information on the DISH Reporting and Audit Requirements. So basically what that said was uncompensated costs include only those costs for Medicaid eligible individuals that remain after accounting for all payments received, including the Medicare and other third-party payments. Well, as of December 30th of 2018, CMS said, nope, ignore those FAQs 33 and 34. So you can include the cost for those Medicaid, other eligible, and those crossover payments or costs, but you don't have to include the payments. So you're including all the costs, but not the payments. So, right, your uncompensated care cost is going to go way up. Well, states had the option to revise these DISH audits, so they removed those third-party payments or Medicare payments for services provided prior to June 2nd of 2017. And then August 13th, 2019, that final rule was reinstated for services provided on or after June 2nd of 2017. So all of the services provided June 2nd and later now we're going to calculate those third-party payments. So it reduced those uncompensated care costs, and those 2018 audits there, I think there was a lot of hospitals that were overpaid because something you have to think about is not only is this affect the audit, but when the states were calculating the initial payments, and it was kind of a mess. But that's kind of the way Medicaid works. So, a lot of hospitals were overpaid in those 2018, 2019 years, and hopefully these Medicaid programs are kind of catching up, and maybe we're not going to see all those overpayments again. But that's why these DISH audits are so important, and it's so important to make sure you're capturing all of the eligible cost. So you don't have to owe back money. A lot of these hospitals, this is 3 years later that you already received the payments 3 years ago, and now you're calculating the cost, and who wants to go to their boss and say, hey, we owe back millions of dollars. I know I wouldn't want to do that. So everything we're trying to do is just prevent you guys from doing that. And so going forward, we are, well, it's changing a little bit, but we are including those payments for Medicare and those third-party payments for those Medicaid other eligible. So the Consolidated Appropriations Act of 2021, so it did create new supplemental payment reporting requirements for states. So these are non-DSH programs. So your uncompensated care pools, your low-income pools, your graduate medical education. So it does require states to put in new regulations to calculate cost, basically to audit. So you're in future years, you're probably going to see a lot more DSH examinations or similar audits similar to the DSH examination for these other supplemental payments that might not have had it before. And then there are changes to the calculation of the hospital-specific DSH limits, and those are effective October 1st of 2021. We'll talk about that in just a minute. But what this act also did was eliminated the reduction for fiscal year 2021. So when I first got into Medicaid, I started with the Medicaid program, and I was told that, you know, you're still going to have a job, but DSH might be going away because our, you know, purpose was to run the DSH program and all the other supplemental payment programs. And that was a long time ago, and these DSH cuts never went into effect, and they just kept delaying it. So what this act did was just got rid of that very first year, so that fiscal year 21 where it was supposed to start, got rid of it completely, and then delayed the remaining 4 years to 2024. So they'll cut it by $8 billion, which is more than half of the allotment for 22. So when it gets closer to, you know, next year, I can't believe it's already here, but when it gets closer to that, we'll see, are they actually going to go through with these cuts? I'm interested to see how that will come into play. So one of the biggest things that this act did for the DSH program, the updated UCC calculation, so the costs associated with the dually enrolled individuals will no longer be included in the hospital's uncompensated care cost. So that is your Medicare or private insurance and Medicaid. So where Medicaid is secondary. So right now we're including those in the Medicaid other eligible, but they're going to get rid of that. So we're no longer including those costs. We're no longer including those payments. So the updated UCC calculation will only allow for the inclusion of costs and payment for services where Medicaid is that primary payer. Although most states will not be able to include costs related to the dually eligible individuals, there are some exceptions to the new rule. Some hospitals may still be able to continue including the cost and payments associated with those dually eligible, you know, your Medicare or your commercial and Medicare commercial primary with your Medicaid secondary. But in order to be eligible for that exemption, hospitals must be in the 97th percentile of all hospitals in the number of Medicare SSI days, or the percentage of Medicare SSI days to total inpatient days in its most recent cost report year. And that is effective October for services, October 1st to 2021. So our DSH payments that we're receiving right now, or maybe we received last year, hopefully these states considered that when they were calculating these payments, because it will be a big drop in the UC calculation for some hospitals. But going forward, you know, the audits might be a little bit less work. And Myers and Stauffer, I don't believe, has released how they plan on doing that, because these audits, they go by a specific hospital's cost report year and not just the state fiscal year. So they might do kind of what they did with the FAQs 33 and 34, where they would take a percentage of that cost you're calculating based on how much of the cost report year covered or was before June 2nd of 2017, and then how much was after. So, you know, Myers and Stauffer does do specific state training. So I recommend everyone joining that. You know, this presentation, I just wanted to kind of get everyone together and give you some tips on how to start preparing But doing that Myers and Stauffer training, hopefully they give a little bit more insight on this and how they actually will implement it. I'm not sure if CMS has released some more regulation and guidelines that must need to be followed, but something we probably want to, really follow closely. All right. And that's all I have today. I just want to thank everyone. We can open it up to any questions that we might have. Give you a couple minutes for that.
If you do have any questions for Brooke, please go ahead and put them into the chat.
And also, if you have any state-specific questions, feel free to send me an email or contact me directly, and we can get those questions answered for you as well.
Well, Brooke, it doesn't look like any questions are coming in. Thank you so much for the great presentation. And thank you everyone for joining us today. This does conclude our webinar. I did place in the chat box a link to our survey. If you could please take a few minutes to complete this, let us know what you thought about the presentation. Also, just a reminder, a copy of today's slides and a recording of the event will be sent to you in the next few days. So please make sure to check your inbox for that. In the meantime, please give Brooke a call if you have any additional questions. Also, we'd like to invite you to join us on March 21st. We will be holding another webinar, Getting to Know Medicaid, Program Basics and Reimbursement Opportunities. Watch your email for this invitation. And thank you and enjoy the rest of the day, everyone.
Thank you, everyone.